Welcome to A Psychologist Talks. Today we're going to be talking about schizoaffective disorder. This is a diagnosis found in the schizophrenia spectrum conditions. It's going to be probably a series of episodes based on diagnoses. Schizoaffective disorder I find to be particularly important because I think it is highly misunderstood and thereby misdiagnosed quite a bit. So first, let's start with what schizoaffective disorder is, and then I'll get into, I think, the major points of confusion when it comes to diagnosis. So what it is, it's, again, part of the schizophrenia spectrum. This idea of it being on a spectrum is a really important change for the DSM because it's a slow, and you will likely hear this on other episodes, kind of an incremental step towards understanding conditions from a more continuum-based mindset rather than merely a categorical mindset. So it's on the schizophrenia spectrum, and there's only a few conditions that hypothetically exist on the spectrum right now. And one of them, the dominant ones, is like short duration schizophrenia form, very rarely diagnosed. This is like front end stuff. The one that most folks are aware of are schizophrenia itself. But schizoaffective is on the same family. And then another one is schizotypal personality disorder. This actually I want to give credit to psychodynamic theories because they have long argued that schizotypy, sort of schizotypal personality, is more similar to schizophrenia and maybe is like seen as like a really high functioning or put differently, the positive symptoms aren't so pervasive. Well, it's not that they're not as pervasive, they're not as all encompassing. There's this sort of eccentricity with schizotypal that isn't quite the same as schizophrenia, where there's really an entrenchment in the psychotic symptoms. So, long story short, though, we're talking about schizoaffective disorder, but it's a really important point that it's in the family of schizophrenia, which we'll get to later. The simplest way to put it is that schizoaffective disorder is schizophrenia with a mood component superimposed on it. So there's a typical schizophrenia experience. This is psychotic episodes. But then somewhere during the duration of these protracted psychotic episodes, there's a major mood component, whether it's a bipolar component or a depressive component. And the DSM, the Diagnostic Manual, talks about like a common trajectory is a development of psychotic symptoms, and then a major mood episode will start to occur. And then when the mood episode goes away, there's still lingering psychotic symptoms. And this is really key because it's what differentiates it from, say, major depressive disorder with psychotic symptoms or bipolar 1, where the mania can have psychosis, because in those cases, the psychosis is only occurring by virtue of the presence of the mood episode. So the psychosis comes because of the depression or in tandem with the depression, or the psychosis comes as a result of a manic episode. Schizoaffective, you have the psychosis that lingers beyond, and then a mood episode, and then again, psychosis lingers once beyond that mood episode. So that's a real key and critical piece, because otherwise you should be diagnosing something else. Now, one of the other interesting factors with schizoaffective is how challenging it is to actually merit the diagnosis. So the thing the Diagnostic Manual has spoken about in at least the last two iterations has been the need for the mood episode to be observed over a long period of time, because this mood episode or the dominance or predominance of the mood episodes needs to be established. It can't just be like, oh, they had a single mood episode over the entire course of a year and it lasted 3 weeks. They're talking like 50-ish% of the time there's some major mood component during active phases of the condition. And if you think about like how frequent active phases of the condition happen within schizophrenia spectrum conditions, it's not like it's a 24/7 all 12 months. It happens in periods, 6-month periods, but there are gaps where things improve a little bit. But when the active phase recurs, you're looking for mood, a big mood component. But if you do the math there, it's going to take over a year to really establish the not the frequency, but establish the it's not frequency, it's the dominance or the likelihood that a mood episode is going to keep recurring, which is what qualifies the shift to a schizoaffective disorder. Which, when you think about treatment and diagnosis, multiple years potentially to really establish something like this. Now, that's not outside the realm of possibility, because folks who are dealing with schizophrenia are usually in treatment for multiple years. So it's not like they're in for 6 months and they disappear. I mean, some do because they're pulling away from treatment, or they get disorganized and paranoid, or they just don't want to keep coming into treatment due to stigma. There's lots of reasons, but by and large, once they're in treatment, they can be in treatment for several years, decades even. And so those couple of years aren't really the end of the world if you're following one of your patients for a long time, or if you're a patient, listening to this episode and you're going to your provider, you might have developed quite a longitudinal relationship with a provider, or at least an organization. And so it's not outside the realm of possibility to be able to look for these patterns over several years. Still, there's not a lot of other conditions that say you got to be observant for multiple years. So it is quite remarkable when you think about it. So those are kind of the major components. The mood component is what differentiates it. But a big emphasis is that it still has to meet criterion A of schizophrenia. And criterion A of schizophrenia is 2 or more psychotic-related symptoms, or positive symptoms. Positive symptoms are the addition of something that's not typically in the human condition. And so it's got to be more than one. It can't just be hallucinations. It can't just be paranoia, delusions. There has to be 2 or more. And if you're curious, you can look that up. So it's a pretty significant condition, and it's really important to remark upon the dominance of mood-related concerns, because while schizophrenia can have mood-related problems, it shouldn't in of itself have like a dominant mood component, and hence the shift. The last note I'll make is that the diagnostic manual says to providers that if the mood episodes begin to dissipate or not recur, you're supposed to shift the diagnosis back to schizophrenia. So that might not seem terribly remarkable, but this is a good segue into why this is misunderstood, why the diagnosis is misunderstood. So what I often see providers do, I work in community mental health. We the incident rates in the general population for schizophrenia are not astronomically high, but in a community mental health center, we see a lot of folks with these diagnoses just by virtue of the type of facility we are. So we naturally have high incident rates, higher than the general population, just because of who we see. But what's interesting is the diagnosis of schizoaffective is astronomically high. And there's a lot of misdiagnosis that's occurring because the incident rates and the prevalence rates for schizoaffective are technically, I forget if the newer DSM suggests anything different, but the last one are technically lower than schizophrenia, because a lot of cases of schizophrenia do not end up having a major mood component, and so schizoaffective just isn't quite as prevalent. And yet, I have tons of providers that are diagnosing schizoaffective, and anecdotally, I see it way more than I see a diagnosis of schizophrenia. And that's because I think what we're doing is there's 2 different diagnostic categories that we're actually diagnosing schizoaffective, one correct and one incorrect. So the incorrect way is essentially, I'll kind of paint a picture of the typical patient that garners this diagnosis incorrectly. Say a client comes in, they have a major mood component of some sort of bipolarity, or they're going through a lot of depression and moodiness, and maybe you're not wanting to go down the route of bipolar. But then they're also complaining of a psychotic symptom. The most common one that we hear is things like hallucinations. More often, it's auditory hallucinations, one of the most common hallucinations that folks experience. And as I will note in a moment, can be experienced outside of schizophrenia spectrum too. There's every once in a while, visual abnormalities, and then some paranoia a la carte sometimes does come up and people will complain about it. But these cases, that's where it will end. It will just be, I hear things, or I hear things and I see things, or something like that. Now here's the problem, is that's not criterion A of schizophrenia. So how it's often described in these folks that are misdiagnosed schizoaffective, they're not talking about like, I hear things and my behavior becomes really out of sorts and I withdraw from all sorts of things and it's lasting for 6 months. It dominates. I mean, they're just absolutely enveloped by these symptoms. What these other folks will describe of like, yeah, I have hallucinations. They've kind of always been there to a certain degree since, I don't know, since I was age 16 or something. How interruptive are they? Sort of. I mean, they can be. They're certainly distracting. How long do they last? Well, it could be like 5 minutes, 10 minutes. Maybe if I'm having a bad day, they're kind of floating around there all day. Or are they like impossible to ignore? No, I mean, they're distracting and they get my way. But no, I'm going about my way still. It's just they're really bothersome. And you ask, like, next to the mood things, do they happen outside of when you're feeling moody or when you're not sleeping and you don't need it, or, basically assessing for the mood component? They're like, yeah, it's still there. And this is where folks are like, it must be schizoaffective. And it's like, no, it's not. No, it's not. Because it's not schizophrenia. I mean, I have to go back to the central point of you have to be willing to say this person has schizophrenia to say that they have schizoaffective disorder. And what I just gave in that description of hallucinatory experiences and psychosis is not the same type of psychosis we're talking about with schizophrenia. This protracted, very enveloping, very severe psychotic episodes with 2 or more symptoms. It's not what we're talking about here. And that's where the error is occurring. This psychosis is better ascribed to something else. So common ones that will come up is like, I say in another episode about like organizational level. Folks who are have more functional problems across domains, secondary to mental health concerns, particularly personality. They are more prone to psychoticism, not full-blown psychosis, but these breaches in reality testing, particularly under acute stress. They'll have complaints of this sort of stuff, but it's not these dominant 6-month, all-encompassing episodes that we're talking about with schizophrenia. So a common one where I hear this floating around is like borderline personality disorder. And obviously you got to keep your eye out for schizotypal personality disorder just in case. Again, there's this sort of oddness and eccentricity to them that really does make them stand out. Whereas these misdiagnosed folks, unless they told you they were having hallucinations, you never have any indication there was anything schizophrenia spectrum. And spoiler, it's because there isn't. So these under times of acute distress, folks, lower organizational levels for personality related concerns, again, particularly borderline personality disorder. I'm not trying to stigmatize them more, just the chaos and the fragmentation that sometimes happens in these cases can incline them to psychoticism. But again, it's just hallucinations. It's not all encompassing. There's a sort of transience to them. There's a stress reactivity to them. And often they're going to be triggered by certain contents. So, the stereotype, and I think stereotype for good reason for things like borderline is relational distress. Another area where it can come up is post-traumatic stress, particularly when you're leaning more towards the kind of dissociative side of things. Like we're talking really severe trauma where there's a lot of acute, like there's a baseline of acute distress and sort of an inability or a challenge of really dealing with emotional states. And so you can get dissociative processes, which is a whole other episode. I know there's a lot there. Kind of dissociative-like processes where they're checking out from reality. The other thing is there's breaches in reality testing where you'll hear, again, these complaints of like voice hearing or complaints of shadows in the corners of their eyes and those sorts of things. But again, it's just like we were talking about with the personality component. They're transient in nature. They're not lasting. It kind of comes in and out. And often there's thematic ties to either the traumatic content or, again, something peripheral to it, like relational distress or something like that. So this is it's very distinct. It's very separate from what we are technically saying schizoaffective disorder is, a highly genetic schizophrenia. Remember, schizoaffective needs to change to schizophrenia the minute a mood episode's gone, because the criterion A is probably still going to be there. Criterion A of schizophrenia. They're just wildly different things. Now, I don't necessarily blame providers for doing this, because the DSM, the Diagnostic Manual, does not do a good job explaining what to do with psychoticism that isn't schizophrenia. It just doesn't do a good job. And so this leaves providers in this interesting lurch where there's this increased prevalence of reporting psychoticism, but nowhere really economical to put them. The way I say it is, if it's truly really brief and transient in nature, it's not really a protracted thing. It's something that you would very much anticipate would go away if high levels of stress go away. So again, these little kind of markings of hallucinations or feelings of paranoia, I subsume them under these other diagnoses: PTSD, borderline personality disorder. I just note like a little bit of psychoticism might be anticipated or expected. And I should note too, I engage in psychological testing, and when I give folks the Rorschach ink blot, which some people are like, oh my gosh, what an outdated. No, it's a very updated measure, and even when it was getting criticism back in the day, when it was getting scientifically revamped, nobody ever challenged how good it is at testing reality testing and psychosis. And so when I test folks that I'm talking about, more trauma, personality related, they come up relatively clean on Rorschachs as well. I've not run a study on this, but anecdotally, when I give these, there's some unusual ways of seeing the world, often interpersonally related, but not like gross distortions of reality like we would anticipate with schizophrenia. So just kind of giving further kind of credo and evidence that we're talking about two different things. The expression of the symptom might be quite similar, but the underlying etiology and fundamentally what's going on internally is different. It is different. So I'll sometimes subsume it, kind of house it underneath these diagnoses. However, what do you do if they're like, no, it's like there most of the time, it happens multiple times in a week, and it's been happening for 10 years straight, doesn't seem to terribly go away? Well, don't give schizoaffective. The answer is a frustrating one to me, but I like it and I don't like it. So if you're a provider, you're probably already familiar with this. If you're not a provider, you might not have heard this before. It's the other specified category. This is synonymous to the old DSM, I think it was 4 and before, the not otherwise specified. So it was the NOS category. But they changed it to an unspecified and a specified. Unspecified is basically saying, like, I need time to figure this out. The specified says, no, we figured it out. It just doesn't fit these other things in the same family. So you've got the schizophrenia spectrum, and then you've got other specified schizophrenia spectrum, and I think it says N-related. They're always a mouthful. N-related disorders. And that's where I would house this. Now, the frustration point with this diagnostic category is it's often so broad, so incredibly broad. You look at, say, other specified trauma and stressor-related disorder category. It can range anywhere from an atypical presentation of PTSD or to a healed, kind of far, vastly improved PTSD to an unusual adjustment reaction. I mean, it really just totally runs the gamut. And the reason why that's frustrating is it's super nondescript. Like, someone has to know what the heck you're talking about if you put that into somebody's chart of like, well, how do I understand it? Well, heaven, for heaven's sake, hopefully there's a description, a little paragraph, so that providers understand why the heck this other specified was given. But this is where you would put it. It's basically saying, look, this individual is complaining of to a certain degree, intractable psychotic symptom, often hallucinations, maybe a little very mild, extremely transient paranoia that kind of perks up again, usually as a result of some sort of relational distress or suspicion about safety. Again, something thematically related to these the dominant diagnosis. But I want to note it because it's significant enough that I can't house it anywhere else. And so that's what it's there for. And it's especially important to avoid giving erroneous schizoaffective disorders because it's just not that. It's just not that. If you need any further evidence, I mean, the treatment for, or not evidence, but encouragement, the treatment for schizophrenia is quite significant. It has a certain prognostic, not an indicator, but a kind of prognostic backing to it that is very different than if you were to give another specified. In fact, when, again, this is anecdote, but talking to psychiatrists, the types of referrals that are sent my way for psychological testing, all this sort of stuff, when you give antipsychotics, atypical antipsychotics to these individuals that are having the more kind of transient other specified stuff, often those antipsychotics are not appreciably affecting those psychotic symptoms. Why is that? Because when you give those sorts of medications to someone with full-blown schizophrenia or legit schizoaffective, you see quite a significant softening, if not elimination, of those symptoms, and you just do not see it with these other reported hallucinations that just continue independent of mood. Again, because there is something fundamentally different here. So that's the big confusion point. And again, I understand that confusion point because there's nowhere it's not intuitive of what to do when people are complaining about an intractable or recurrent psychotic symptom. But that's not schizoaffective disorder just because there's another mood component that crops up here and there. It is a very distinct, very different thing. Schizophrenia and the family of schizophrenia disorders needs to be respected as its own entity. It's very separate than the psychoticism that can arise independent of schizophrenia, which I'm likely to have another episode about. But for today's purposes, we're talking about how to differentiate and how to diagnose schizoaffective disorder. Whether you are a practitioner, hopefully this has been helpful, but also if you're on the receiving end of the diagnoses our profession provides, hopefully that was insightful and helpful. And always stay curious.